Hi guys, once again Ijaz Hidayat is with you with a new interesting topic. Today my topic is surgical mitral valve replacement versus robotic mitral valve replacement or repair versus transcatheter mitral valve repair in cath lab with the support of extracorporeal membrane oxygenation. So it is very vast topic today. We'll try to brief in a short so people can understand what is different between the conventional mitral valve replacement versus robotic mitral valve replacement versus TMVR, mean transcatheter mitral valve implantation or repair or replacement. So let's start with the conventional mitral valve replacement, or you can say the surgical mitral valve replacement. Is, as you know, we are using our routine ordinary methods that we open the chest. Surgeon cannulated SVC, IVC, and he cannulated the ascending aorta to establish bypass, and by decreasing temperature around like in a drift or some 32 degree or 30 degrees Celsius. So with hypothermic, they used to do the mitral repair or replacement. This is the routine or conventional method we are doing. But as going to compare with the robotic surgery, so in a robotic mitral valve replacement, like especially for the mitral valve, so what is happening here, what is the difference of the as a conventional and the mitral? Robotic is in the robotic surgery of surgeons use the joystick, and he was sitting on the computer. He is not scrubbing actually. And the other surgical, the surgeon or assistant who was just assisting to the robot, was passing out, handling the laparoscopical instrument through the thoracotomy, like a thoracic approach, instead of the sternum opening. So there was no sternum opening in robotic surgery. In a mitral valve, they go approach through the right thoracotomy, and with a small incision, right, it's not a big incision, it will be very small incision, and through that they go through into the, and in the meantime they put a trocar needles in the umbilical, and of course one in this side and one from the chest side, and through the laparoscopical they approach to the heart, and the surgeon was manipulating or playing with the joystick, and he doing the dissections and everything through the robot. And so robot is doing actually the procedure, and robot was controlled by the surgeon. And for to establish the cardiopulmonary bypass in robotic surgery, of course in manual you need to cannulate jugular, right jugular vein as a SVC, and femoral vein as the IVC. And for to return for the arterial cannula, usually we are using the femoral artery to establish the bypass. And usually in like in conventional, we are using the Plagisol or standard blood cardioplegia, which affect like a 25 to 30 minutes, and we have to repeat the doses. But here in the robotic surgery, we give either custodial, or we will give the delnido cardioplegia. So my preference is give the delnido cardioplegia. So after releasing the cross clamp, the heart will return back very quickly as compared to with the custodial. So you can use the custodial because you need a long cross clamp timing, because this is not a easy task, because it's not easy going, because it's the initial phase of robotic surgery. It's like in a catheter we are doing. So cardioplegia was delivered through the thoracic cavity with a long needle, or sometimes use the small needle, but with the usage of the laparoscopical, the forceps and the needles, you just puncture the aorta and you deliver the cardioplegia into the ascending route, and heart stopped for 90 minutes, and it can go extend till 120 minutes, and 120 minutes quite enough to replace or repair the mitral valve. And this is the way that we do the mitral valves. In a mitral valve normally is a lengthy procedure. Robotic mitral valve is a lengthy procedure initially, but outcome is good, because you will not, so the patient will not find any scar in any opening in the sternum. So this is similar to the small scars like a laparoscopic cholecyst type as we are doing. So similar, we just inject one true cut here and the true cut two places, so where they can play the manipulate the instrument, laparoscopical instrument, and from the umbilical, of course, there's a camera and insufflator to distend the cavity with the CO2. So as a perfusionist, you have to be very smart to managing the venous return, and for especially for the robotic surgery we are using vacuum assist. So in case if your right atrium distending or LV side distending, so you can just increase the vacuum and or you can decrease the vacuum of the bed, or even you can manipulate with the flow, but not that much, because normally in robotic surgery we are keeping the temperature in drift, so it's mean drift mean 34 or 33 degrees Celsius. So for this you can decrease more flow. So you keep your eyes on your blood gases every 30 minutes, so maintaining the lactate, maintaining the pH, maintaining the PCO2, maintaining the PO2, maintaining hemoglobin hematocrit. So you have to very smart and very smart and be sharp to run the smooth cardiopulmonary bypass with the help of the robot surgery with the robotic mitral valve. So what is different between now the transcatheter mitral valve repair replacement? So what is happening here? What is different as compared to the robotic and as compared to the conventional mitral valve repair? So the patients underwent for the procedure in cath lab. So usually it can go without the support of the ECMO, but usually for the complicated patients you can use the ECMO support. So what the cardiologist do first in the beginning, he prepare the groin and he keep the femoral vein and femoral artery ready one-sided, like for example from the left-sided to establish the extracorporeal membrane oxygenation, and the right side he used the right femoral vein for to enhance his catheter and the guide words till up to by puncturing the septal to approach to the mitral valve. So in this you should be very smart as a perfusionist, so because normally we are maintaining an ECMO established flow like a 2 to 2.5 liter, and especially you should be very smart and be very careful the time the cardiologist plan to insert the delivery sheet, and especially for the catheter, before catheter he puncture the leaflets of the valve, and he inflate the balloon, so before prior to insert the or implant the mitral valve, and there can be the chance of the air you can suck through your that cannula into your venous side. So in case you get any venous side air, so you can just stop your ECMO for a couple of minutes and you de-air your circuit and inform to the anesthetist, so he can make the 100% oxygenation from the ventilator side. But to prevent all these type of scenarios, you can the time he inserting and loading for the dilators from the right side, you can switch off your the ECMO for a couple of seconds or a couple of minutes, or inform to the cardiologist, or to prevent air entering into the system. And throughout the surgery, every 50 minutes we used to do the ACT, and our target to ACT maintaining is like 250 and above, 250 to 300 seconds. So to prevent clots in the circuit, so the target ACT is 250 to 300 throughout the procedure. And as is a perfusionist, we checking the ACT every 15 to 20 minutes till the procedure commended. The beauty of the transcatheter mitral valve repair replacement implantation is that at the end of the procedure you can remove the ECMO cannulas, and patient can shift it without support of ECMO, and it is very helpful, because if your patient is unstable, so the ECMO support will going to help to implant, like in a previous we were doing the TAVI procedure, the transcatheter aortic valve implantation. So now the new technology is transcatheter mitral valve replacement. So hope you get it, the small information, the difference between the surgical mitral valve replacement or repair and as versus robotic mitral valve replacement or repair, or versus transcatheter mitral valve implantation or replacements. If you guys have any queries, questions, please mention in my links on the comments box so I can answer better, or we can share our experience so make a more things comfortable better. Have a nice and good day. Take care. Bye bye.